Great pleasure to introduce you, Sam. Go.
Thank you very much. Hello, my professor and my colleagues. We're going to talk about the physiology of coagulation and maybe giving a hint about coagulopathy. The objectives of our talk today, at the end, we should know what's the meaning of hemostasis, the steps of hemostasis, role of each component of hemostatic mechanisms, and what is the meaning of coagulopathy. First, we should ask a question. What is keeping our blood thin? Actually, we have three natural mechanisms. Number one, the intact endothelium release nitric oxide and prostacyclin I2. This inhibits the platelet adhesions. Number two, the heparin sulfate, which is secreted endogenously, which act with antithrombin 3 and making a complex, inhibits already factors 2, 9, and 10. The thrombomodulin thrombin complex, which activate the protein C, and active protein C in turn inhibits factor 5 and factor 8. These three natural mechanisms maintaining the fluidity of the blood. Then, what is the meaning of hemostasis? Hemo means blood, stasis, it means to stop. So it is a physiological mechanism, the process of blood clotting formation at the site of vessel injury. So once we have bleeding, the hemostatic response started as quick as possible to stop bleeding and prevent blood losses, and should be localized at the site of injury only to prevent the thromboembolic manifestations and be regulated by certain mechanisms. So we will go briefly, then we will start to talk in details. We have four components for the hemostatic process: the blood vessels, the platelet, the clotting factors, and the fibrinolytic system. The blood vessels start to vasospasm with the bleeding. Then after that, the platelet form the platelet plug, which help in stopping of the bleeding. Then after that, starting of the coagulation cascades, which is, as we know, the extrinsic and intrinsic pathways, ended with the common pathways, then ended by formation of fibrin and the clot. Then after that, the clot retraction mechanisms, then removal of the clot by the fibrinolytic system. This is in brief. So this is the four component, as we said, for the hemostatic response. What is the role of blood vessels? What is the mechanisms of blood vessels making it vasoconstrict in response to bleeding? We have three theories. Number one, the humoral theory, due to release of some mediators like endothelin, thromboxane A2, 5-hydroxytryptamine, and adrenaline. All these mediators act directly to vasoconstrict the blood vessels and help to stop the bleeding. We have another theory, the myogenic theory, which affected the smooth muscle of the wall of the blood vessels, making it to contract and vasoconstriction occur. And we have nervous mechanisms due to stimulation of nociceptors due to pain induced by the trauma or by the injury. The formation of platelet plug started with platelet adhesion, aggregations, secretions, and the procoagulant activity of the platelet. The platelet adhesions start by deposition of platelets in the subendothelial matrix and which bind with von Willebrand factors, which is a very important factors present in the endothelium. And once we have injury, endothelial injury, the von Willebrand factors become activated and attract the platelet to be bind with it at the site of injury. And after that, we have release of some mediators in the circulation, which aggregate the platelet to be deposited on the site of injury. and which secretes some, and the platelet also secretes some granules which help in the formation of the platelet plug. And by the way, the platelet has a procoagulant activity which already stimulate the clotting cascades by thrombin generation. So this diagram just showing how the platelet plug start to be formed as a site of injury by platelet adhesions and aggregation to the site of injury. What makes the platelet activated? We said before the three natural mechanisms making the platelet inactive form. But once we have injury, the platelets start to be activated by releasing of some mediators. These mediators like thrombin, collagen, ADP, epinephrine. ADP, by the way, this is the site of action of clopidogrel, one of the antiplatelet. Both of them are very strong activator, like the collagen and the thrombin, and ADP, epinephrine, we consider it weak activators to the platelet. The platelet adhesion is starting by morphological changes of its shape and make it extremely adhesive. And as we said, von Willebrand factors like or loves to bind with platelet, and the platelet is the same at the site of injury. So once the platelet start to has morphological changes, directly it transfer or bind to the site of injury with von Willebrand factors at a specific receptors. So each platelet has a specific receptors for von Willebrand factors. This has happened in the subendothelial matrix. And this receptor is called glycoprotein 1b. So glycoprotein 1b and von Willebrand factors both are very important in the platelet adhesions. Deficiency of each component, the glycoprotein 1b will lead to a syndrome which is Bernard-Soulier disease, and von Willebrand factors will be affected if we have deficiency in it, and it's bleeding disorders, and it has 4 subcategories under it. So von Willebrand factors, fibrinogen, and the glycoprotein 2b and 3a, these 3 components are very important in inducing platelet adhesions and aggregation. We will start from the right side of the screen, the von Willebrand factors, which bind directly to glycoprotein 1b receptors in the platelet wall. This activate or stimulate the platelet adhesions, and it has a role also in clot retraction later on. By the way, the platelet itself cannot bind directly to each other without the presence of fibrinogen. The fibrinogen has bivalent symmetrical, it is a bivalent symmetrical molecules and able to bind with 2 receptors on 2 platelets. So it has the ability to bind 2 platelets in the same time and cross-linking them to make strong platelet plug. These receptors, it is the one specific for the fibrinogen. So it is abundant on the platelet surface, has low affinity to fibrinogen under the normal circumstances. But once we have injury, it turns to high affinity to fibrinogen. So these 3 components has great influences in platelet adhesions and aggregation. This diagram will summarize this. So von Willebrand factors will start to bind with platelet through this receptors, glycoprotein 1b, and after that, some mediators will be released, ADP, thromboxane A2, 5-hydroxytryptamine, which increase the platelet aggregation to the site of injury. Platelet co-adhesions will be through the fibrinogen, which has 2 ends, and specifically bind to the glycoprotein 2b, 3a, and by the way, also this is the site of action of antiplatelet abiseximab. Then after that, the role of clotting cascade or clotting factors. We all know the intrinsic pathway and extrinsic pathway ended with the common pathway. By the way, the extrinsic pathway, it takes almost 30 seconds to be completed, and intrinsic pathway, it takes about 4 to 6 minutes to be completed. But this model, it was helpful in interpretation of some laboratory tests like prothrombin time and activated partial thrombin time. But it is actually inaccurate physiologically. So they have two things more to explain what's happening in the coagulation process. Number one, the thrombin generation. They are talking about thrombin generation. Number two, the multi-components complexes. So thrombin generations has 4 phases. Phase 1 starting by when tissue factors activate with activated factor 7, this combination activate factor 10 and starting to initiate or generate some thrombin, a little of thrombin. And thrombin and activated factor 11 has a feedback manner. This is starting, and this is the primary response to the bleeding. Then after that, the thrombin is starting to be more generated. This is phase 2 amplification with the aid of activated factor 5, 8, 11, and the platelet itself. Then propagation, more and more thrombin, and then after that, cessation of the thrombin generation. Then thrombin, if we consider the clotting factors, which are 12, it is like a football team, but 12 rather than 11. We consider the thrombin is the playmaker of the team, and the fibrin is the striker of the team. The multi-component complexes, they introduce that to explain the intrinsic and the extrinsic pathways. They said that we have 3 procoagulant complexes and 1 anticoagulant complex. Each complex has enzyme, cofactor protein, and enzyme substrate. So this is a 3 procoagulant. The extrinsic 10As, this stand for factor 10, 10As, intrinsic 10As, prothrombinase, and protein C anticoagulant. After that, with the continuation of the coagulation cascade after activation of the factor 10, which combined with the platelet factor 5 converts 1 prothrombin to 1 thrombin, and thrombin converts fibrinogen to fibrin with the help of activated factor 13, which is stabilized and cross-links overlapping fibrin strands. And experimentally, they found that the mice lacking factor 13 forming 1/5 clot size in comparing to the normal one. So factor 13, which is calling the fibrin stabilizing factor, as we know. So what is the control mechanism of this process, and what is stopping the coagulation progress? Number 1, dilution of the procoagulant in the blood flow. Number 2, removal of the activated factors through the reticular endothelial system, especially in the liver. Number 3, control of the activated procoagulant and the platelets by natural antithrombotic pathways, as we mentioned before. And we have 2 endogenous pathways to inhibit the coagulation, which is tissue factor pathway inhibitor and C1 esterase inhibitor. The tissue factor pathway inhibitors, it circulates already in the plasma with a very low concentrations and directly inhibits factor 10 and inhibits tissue factor and aggravated factor 7. The C1 esterase inhibitor, it is a member of the serine protease inhibitor sensitized in the liver and inhibits activated factor 7. What else controlling the termination of coagulation? The serine protease inhibitors. the antithrombin 3, as we said before, the clotting initiated inhibitory process, the protein C pathways, in addition to prostacyclin, thromboxane A2, and nitric oxide. Then the role of the fibrinolytic system. It is activated to restore the vessel patency following hemostasis and to prevent the extension of the clotting. The clot must be organized and removed by the proteolytic enzymes plasmin in conjunction with wound healing and tissue remodeling. The plasminogen activated by the tissue plasminogen activator first and turn it to fibrin. Binds to fibrin and activates plasminogen to plasmin. Plasmin cleaves polymerized fibrin strands and release fibrin degradation products and D-dimers, and cleaves also fibrinogen and a variety of plasma protein and clotting factors. So this is the physiological process. So what is the pathology regarding this process? If we have a pathology, so we have a coagulopathy. Coagulopathy, it means we have excess bleeding or thrombosis. It is happened with element, either with element missing or element dysfunction. So if we have element missing or element dysfunction, it leads to either bleeding or thrombosis. So we have now coagulopathy. So if we just reviewing the causes of coagulopathy regarding each component, so regarding the blood vessels, we have vitamin C deficiency, the scurvy, hemorrhagic telangiectasia, Ehlers-Danlos syndrome, which is a connective tissue disease affecting the blood vessels and leads to bleeding. If we refer to the platelet dysfunction, we have thrombocytopenic purpura, as mentioned with Dr. Sawi, Bernard-Soulier, which is deficiency or mutation in the receptors glycoprotein 1b. It leads to morphological changes and leads to macrothrombocytopenia. And we have Glanzmann thromboathenia and platelet storage ball disorders, no granules which secreted in the blood, and thrombocytosis, which leads to thrombotic manifestations. The clotting factors disorders, either bleeding or thrombosis, any deficiency in one of the clotting factors will lead to bleeding. And we have the thrombotic manifestations with protein C deficiency, protein S deficiency, and antiphospholipid syndrome. We have another general disorders like liver diseases affecting the clotting factors synthesis, like the vitamin K and the others. Where infectious disease may affect the bleeding disorders, excessive blood transfusion, trauma, and disseminated intravascular coagulopathy. At the end, we have another question. Where is factor 6 in this process? Is there a factor 6 in this process? Thank you.
Thank you, Sam. Thank you.